Good morning, everyone. Can everyone hear me in the back? Can you hear me in the back? Perfect. How's everyone doing? Good? Great. So this morning we're going to be talking about secondary osteoporosis. And secondary osteoporosis is common. It is not often sought after, but it is frequent in regard to, when I see patients, about 50% of them have additional secondary etiologies that require additional laboratory testing, sophisticated testing, not just like a blood count, chem panel, things like that. So it is a frequent occurrence, and often, as we'll discuss in our cases this morning, it leads to a diagnosis of underlying metabolic bone disease or mineral disorders, which should also be treated, and in many cases treated prior to the institution of our usual anti-osteoporosis pharmacologic therapy. If you don't treat these disorders, then your pharmacologic therapy may not be effective or may be detrimental to the correction of the underlying mineral disorders. And we'll get into this as we move through our series of patients this morning. So let's start by discussing our first case, which is a 65-year-old female, asymptomatic, T-score of minus 2.7 at the right femur neck. She's anxious because her best friend died after sustaining a fragility fracture of the hip. She's asymptomatic. She has no major symptoms. Good daily calcium intake, vitamin D intake. Menopause at 50, no HRT, no alcohol of excess, caffeine or sodium, no cigarette smoking, active lifestyle. Family history negative for osteoporosis. She's on Oscal 500 once a day, and vitamin D 1,000 units a day. You see her weight and height. She has no other relevant clinical findings on examination. So our first question is, at this stage, what would be the laboratory studies that you might want to consider of these that are listed, your initial ones? So I think we're pretty close to 18 out of the 40-so people in the audience. That means to me that the other folks in the audience are not sure. Okay? I think that of those that voted, the question is whether you have a referral practice, meaning you're a tertiary referral practice, or you're a primary care provider seeing your patient on an initial basis, because it does make a difference in regard to what you order or what you can or should order. So for example, a comprehensive metabolic panel, that would be a Chem 21, so you would have a variety of other studies in that, not just a basic chemistry panel. If you're concerned about calcium disorders, you would certainly order an ionized calcium, but it's not usually the routine to order an ionized calcium just on the basis of initial evaluation of a patient. Serum magnesium, certainly when you are looking for calcium and mineral disorders, but not often just as a routine review of a patient. So I think that when we see the 22 of the 40-some individuals in the audience ordering all three, then you're looking for secondary etiologies, but not necessarily a basic initial review for usual primary care physicians. Next, what additional laboratory studies of these would you consider? All right. So again, those that see patients with osteoporosis and wish to consider a more comprehensive evaluation may go directly to a serum parathyroid hormone level. Most individuals in a primary care setting would perform a vitamin D, a 25-hydroxy vitamin D level. There is no necessity to do a 125-dihydroxy vitamin D level because this is only done in certain clinical situations. Okay, next. Again, which of the following laboratory studies would you order on your patients? Serum phosphorus, serum tissue transglutaminase antibodies, for celiac disease, serum estrogen level, none of the above, or all of the above. Now this is getting a little bit trickier, right? We can't make it too easy. Now remember, I heard from about half of you that you would do a comprehensive laboratory assessment, yet when I'm pushing you, it's interesting to see what you're not ordering. You're ready to order a parathyroid hormone level, an ionized calcium, and a magnesium. But in a comprehensive tertiary care center, you may also wish to consider tissue transglutaminase antibodies. You would not often do a serum estrogen level, but you would consider a serum phosphorus level, which is characteristically not performed in a comprehensive evaluation for underlying mineral disorders. So the majority of individuals said none of the above. And so this is very interesting to me because of what I just had mentioned to you. You're willing to do a comprehensive assessment, but serum phosphorus is not usually ordered in an evaluation. And we know that serum phosphorus balance, as we'll talk about with parathyroid hormone, hyper or hypoparathyroidism, is a significant mineral that needs to be assessed, but characteristically is not ordered. All right, let's proceed. Would you do a 24-hour urine calcium, a serum alkaline phosphatase, bone-specific? These are isoenzymes. I would do a bone-specific. Serum uric acid, none of the above, or all three? All right. So again, the majority of individuals voting today suggested that they would also include a serum uric acid. And I would ask why. Why would you want to know about a serum uric acid in your patients with osteoporosis? You would order a serum urate in those individuals concerned with gout, say, or hyperuricemia for a variety of different reasons, or urate nephrolithiasis, things of that nature, meaning correlating that with a urine 24-hour uric acid. So I'm not sure I would agree with A, B, C or serum uric acid in itself. Bone-specific alkaline phosphatase or isoenzymes are not characteristically ordered initially, but as we spoke yesterday about evaluating patients for baseline bone turnover, you might consider that as part of your evaluation in regard to the patient's underlying bone remodeling rate. So you could do a bone-specific alkaline phosphatase to help you with osteoblastic activity. So that would be for osteoblastic activity, not resorption. So this is not a resorption marker. A 24-hour urine excretion would be useful, and I believe that probably 99% of the time in my patients I would order a 24-hour urine for calcium and creatinine. The creatinine is ordered to assure that you have an adequate collection. And that would provide you with, as we talk about vitamin D deficiency, parathyroid disease, other metabolic bone diseases, a balance. And so you're looking at serum and urine, combining both of them at the same time to look at the balance of minerals and metabolic rates in a patient. Yes, please.
Since we frequently have outcrops on the scan, is that good enough? You know, on a general scan, and then if it's elevated?
So the question is whether a total alkaline phosphatase in a chemistry panel would be sufficient as compared to a bone-specific alkaline phos.
Start out at least.
And I think in the usual way I would say yes, it is very useful to look at a general total alkaline phosphatase, but when you're looking at specific bone diseases, it will not reflect specifically in many patients with subtle disease increased activity. So I've actually seen many patients with underlying skeletal diseases such as fibrous dysplasia, Paget's disease, things of that nature where their ALK phos is high normal but still in the normal range, but the BSAPs are very abnormal. So I think it just depends upon, your what you're looking for, your evaluation. But again, serum, urine, calcium, and creatinine are very important when I evaluate patients. What do you think, Ron? Do you agree with that? Okay. Okay, let's continue on. Common causes of elevated alkaline phosphatase. So now we go back to the young lady in the audience and ask you, okay, so we have an elevated alkaline phosphatase, and this is a total alkaline phosphatase. So what would be some of the common causes of this? All right, we still have some folks that need to press their buttons here. There we go. We're up to 20, 21. So Paget's disease. Paget's disease is a skeletal disease that causes increased osteoblastic activity primarily, but certainly you can see increased markers of resorption in these patients as well. And this would be certainly one of the skeletal diseases that is associated with an elevated ALK phos. Vitamin D deficiency, chronic alcohol ingestion. So most people said A, B, and C, and that's basically the right answer. Because ALK phos is made up of different sources. Remember, total alkaline phosphatase, including the liver. And vitamin D deficiency, insufficiency may not, but certainly significant vitamin D deficiency with secondary hyperparathyroidism, leading to a mineral disorder of bone in the range of just a mineralization disorder all the way to osteomalacia as the extreme, certainly is associated with increased bone-specific alkaline phos, which contributes to the total alkaline phosphatase in patients' serum. All right, common causes of decreased alkaline phosphatase. So we know that there are significant reasons for high ALK phos, but what if you see a decreased ALK phos? So many of these answers have to do with the understanding of systemic disease and the effect on ALK phos, either from the liver, bone, or what have you. So remember, this is not bone specific. So most of the individuals that have entered their score believe that hypophosphatasia, which is a abnormality of tissue nonspecific alkaline phosphatase, a mineralization of bone, mineralization disorder of bone, in which you do not mineralize bone. So you're not actually forming the mineral state of bone, calcium or phosphorus. This is definitely associated with decreased bone-specific ALK phos as well as total ALK phos. Malnutrition. So we also know that individuals that have protein deficiencies have low ALK phos. Celiac disease, from the standpoint of those individuals, not usually just with celiac, but when they have diarrhea as part of a secretory diarrhea state, that is associated as well. And then there's a whole slew of additional potential etiologies, including those diseases that affect the skeleton that cause such low bone turnover that the portion of alkaline phos from bone, as long as the patient doesn't have liver disease concurrently, that elevates it into the normal range, can also result in low ALK phos and more specifically bone specific. And one of those disorders that we commonly see on the bone unit is adynamic bone disease associated with CKD. So one of the forms of renal osteodystrophy, where bone turnover is so low you don't see alkaline phos bone specific generated. There's a variety of other issues. So when you're treating your patients with bisphosphonates and other agents, you see potentially decreased bone-specific ALK phos as a reflection of turning off or turning down the remodeling cycle of bone. So as we discussed yesterday, the agents that we use for treatment of osteoporosis, the anti-resorptives, specifically the very potent ones that turn down osteoblast formation as part of the coupled effect of osteoclast formation reduction, also you will see this as well. So let's talk a little bit about common causes of hypocalcemia. Is this associated with pseudo-hypocalcemia secondary to low serum albumin levels, or hypomagnesemia, or vitamin D deficiency? So if you want to treat patients that have significant disorders of metabolism of bone, we have to appreciate some of these other aspects of mineral disorder and etiologies of those. Yeah. All right. So I think most individuals would pick all three. And one of the things we know about is in those individuals with hypoalbuminemia, very low albumin levels due to a variety of disorders, including inflammatory diseases that shift the liver away from manufacturing albumin to malabsorptive diseases to protein-losing enteropathies, renal loss of albumin through nephrotic syndrome and renal disorders, et cetera, et cetera. All of those conditions can lead to low albumin levels, and that is directly related to binding. Albumin is related to binding of total serum calcium. So we correct for every one decrease in albumin level. So from the normal level of 4, say, we're at a level of 3. Serum calcium, total calcium, is increased by 0.8. Okay, so every time you have every full unit, 1 unit lower in albumin, you increase total calcium by 0.8. Now that's not perfect. That is by far not perfect. so that when we really are concerned about patients who have low albumins and low calcium, we always order an ionized calcium as part of it, which is much more accurate. And as one of the patients I had in the institution, as part of the fracture service, the patient actually had low albumin and normal serum calcium, but when you correct it, I think I mentioned this yesterday, the patient actually had hypercalcemia for 12 years and had not been picked up. So the patient had osteoporosis due to most likely primary hyperparathyroidism that had never been diagnosed, or potentially other causes, but as we know, 12 years of asymptomatic hyperparathyroidism with mild hypercalcemia, certainly this would be an etiology. Hypomagnesemia. So individuals that have hypomagnesemia chronically have decreased parathyroid hormone levels because this is an essential mineral for the calcium sensing receptor, and actually the calcium sensing receptor activity increases and suppresses parathyroid hormone output. And there's decreased sensitivity to parathyroid hormone effect peripherally. So there's a resistance of PTH effect with hypomagnesemia. So this also with decreased PTH, then you have decreased production of 125, you have increased excretion of calcium, and decreased 125, you have decreased absorption through the same mechanism that we'll talk about. With vitamin D deficiency, it's obvious that when you have significant deficiency, you're decreasing 125 levels when you have very low 125D. And we're talking about levels of approximately less than 11 nanograms per ml or lower, where the substrate that is required to have PTH convert and stimulate 1-alpha hydroxylase to 125 levels are so low that you're not actually generating 125D3. So the 25 hydroxy D levels have to be exceedingly low for that to happen, though, because 25D is measured in nanograms per ml, whereas 125 is in picograms per ml. So it's a 1,000-fold difference in those two buckets. So you have to really have very low levels of 25D to have decreased manufacturing of 125. Common causes of hypercalcemia. So let's think about this for a second. Your patient comes to you. You see the patient in the clinic. Patient has osteoporosis, or maybe not. What are some of the common causes of, we're talking about common causes of hypercalcemia. Anybody else wish to take a shot at this? So when we think about common causes, first of all, when you look at ectopic PTH producing neoplastic lesions, meaning ectopic, not PTHRP, but PTH itself, ectopic production is exceedingly rare. This is an exceedingly rare condition. You could almost write it up. Multiple myeloma, that's not a very, it occurs and is in the differential diagnosis, but in a patient who walks into your office, this is not the most common etiology. It is hyperparathyroidism, meaning primary hyperparathyroidism is the most common etiology for outpatient hypercalcemia after correction as well. How about low serum phosphate? The patient comes in and has a low serum phosphate. What do you think about? Does the patient have vomiting and severe diarrhea? Is that associated? Respiratory alkalosis, alcoholism, A or B, or AB C. So we have 18 folks, 19. So most individuals believe that A, B, and C are the etiologies for hypophosphatemia, and they are correct. So certainly electrolyte disorder, vomiting, and severe diarrhea is associated. Respiratory alkalosis is certainly associated due to shifts of phosphorus. Alcoholism is also as part of the refeeding syndrome, and also impaired phosphate absorption. So this is also part of the refeeding syndrome, where people are given lots of carbohydrate as part of during their hospitalization with a shift of phosphorus. Very good. Let's talk a little bit about elevated serum phosphorus. What can cause an elevation of your serum phosphorus? Hyperphosphatemia. What about renal insufficiency, liver cirrhosis, hypocalcemia? So most folks believe that all three are associated with this. So from the standpoint of renal insufficiency, we know that hyperphosphatemia is commonly associated with advanced CKD. Liver cirrhosis, only if you completely destroy the liver. So you will have sufficient 25-hydroxy vitamin D and production of 125D level and absorption of calcium and phosphorus through the intestinal tract. Only when you knock out, you destroy the vast majority of your hepatic parenchyma, over 90%, would you see decreased 25 production, leading to decreased 125D production and decreased phosphorus as part of this syndrome. So elevated levels would certainly not be a common etiology with cirrhosis. Hypocalcemia, only if you had massive or very low, very, very low hypocalcemia. Otherwise, this would not be a common association with hyperphosphatemia. So the take-home messages are listed here. Common causes of hypercalcemia are listed. Okay. PTH-producing tumors, again, these are very rare situations. PTH-RP, which is a humoral hypercalcemia malignancy, is not uncommon in malignancy, and especially solid cell tumors. Granulomatous diseases, these produce increase, any type of granulomatous disease, and actually I have a 29-year-old in the institution at this time with high 125D levels producing increased calcium. So the patient actually has hypercalcemia associated with elevated 125, and just before I left, the ACE level came back elevated, and we're working the patient up for asymptomatic sarcoidosis. So any etiology for granulomatosis, acute fractures, prolonged immobilization leading to reabsorption of bone, release of calcium, hypervitaminosis D, milk alkali. Common causes of hypocalcemia as listed here. From the standpoint of elevated phosphorus levels, I think we can see this as well. And then decreased serum phosphorus as listed. Common causes of elevated alkaline phosphatase isoenzymes, certainly from bone, any type of bone phenomena. And then elevated alk phos, decreased alk phos as listed. This is all in your handout. Okay? So let's go to our next case. This is a patient following risk factors for malnutrition. This is a 66-year-old, this is a 61-year-old male with a fragility fracture of the right humerus. He's single, he's a security guard, he works the night shift, he's a widower, lives alone, he has a poor appetite, smokes significantly, drinks about 6 beers, and has significant cups of coffee each day. He does take a calcium supplement, 1,200 milligrams a day. He takes 2,000 units of vitamin D. His serum calcium is 9.2. His vitamin D level is adequate at 40 nanograms per ml. He's mildly anemic. His MCV is 86. His CMP is within the normal limits, and he's on no medical therapies. So, what are some of the risk factors of nutrition in this patient? I think it's important to note that, okay, we're still clicking here. So most individuals believe that in males at least, being an older male, a widower in this case, and a patient that lives alone certainly are associated by historical content with malnutrition, poor nutrition, especially when the patient's smoking and drinking and other issues like that. Do you want to make any further comments regarding that? Ron.
Can you hear me? Yeah. I just want to mention, very, very important for malnutrition, the people most susceptible to malnutrition are elderly white widowers living alone. The least likely to develop malnutrition are white women on their own. Women seem to be able to care for themselves much, much better than men. But the other reason I brought up this case, these very same people are at very high risk of suicide. So the risk of suicide among white males, widowers, is much, much higher than in any other group of people. And we need to pay particular attention to malnutrition in these patients as well as the suicide risk.
So one of the questions I have for the audience is, how many of the men in the audience actually cook and can cook their own meals? So out of all the males in the audience, there may be 2 or 3. So those of you online, we have about half male, half female in the audience. So now someone stuck their hand up.
Peanut butter and jelly sandwich.
So peanut butter and jelly doesn't count. I'm sorry, we cannot give you credit. So, in fact, men do not cook. They do not know how to cook. They have no clue about nutrition. And this is one of the major issues leading to what Ron had mentioned.
And they often get their calories from alcohol, beer in particular. The other thing is the RDW being elevated, even though the MCV is within the normal range. Because the RDW is elevated, it means that there are quite a lot of small cells, microcytosis, as well as macrocytosis. And this is not a normocytic anemia. It is a mixed anemia of microcytosis as well as macrocytosis. So in your general evaluation of a patient like this, you need to look for causes of microcytosis, especially iron deficiency, and macrocytosis, B12 deficiency, folic acid deficiency. A patient like this is at very high risk of suicide, but also very high risk of malnutrition. And even though he's getting enough calcium and vitamin D from supplements, surprisingly, he's not getting any multivitamin. Many of the people like this I see are on multivitamin preparation, calcium and vitamin D, but they've got lots of deficiencies. If he's deficient in B12, he's at risk of falling. And in fact, this is what happened to him. He had a fall and fractured his humerus. Thank you.
All right. So in the following, in this case, what are the patient's risk factors for osteoporosis? So I think everyone is correct here, and certainly cigarette smoking, excessive alcohol intake, poor nutrition, so we would also include nutritional aspects, and excessive caffeine in regard to usually in the exchange for calcium. So I think that would be my theory. Is that what you would believe too? In this case, the patient is taking calcium, though, in his diet. Okay, so in Mr. BB's case, the diagnosis is osteoporosis. A DEXA scan is needed to confirm the diagnosis. A laboratory workup for malnutrition is recommended. What do you think? Very good. So I think most individuals have the correct answer here, that a diagnosis is osteoporosis. The patient fell, fractured his humerus, and workup is required as well to exclude additional etiologies, as Ron had mentioned, as the reason for his potential imbalance, his malnutrition, which affects bone as well as any other organ system, including muscle. And so certainly a significant workup would be required. A diagnosis of osteoporosis is not required by a DEXA scan, but certainly a DEXA scan would be considered in your serial determination of change based on intervention. Fractures of the humerus are usually preceded by a fall to the side or obliquely forward, are more common in men. Mortality is not increased. What do you think, A and C or A, B, and C? So I think most individuals picked the correct answer here. This is associated with a fall to the side or obliquely. It is obvious. It is actually more common in women than in men, and mortality is increased. So a number of studies, including the Dubbo study in Australia, looked at this and found that mortality and morbidity was increased with humeral fractures. And humeral fractures is obviously one of the four major fractures in FRAX and is considered a major fracture. So the take-home points in this patient's case is factors predisposing to malnutrition include male gender, white race, widower, living alone. And remember, he was on the night shift, so he has no company, he has no individuals or very few to interact with. Depression is very likely. And depression alone, even without SSRI therapy, is associated with increased risk of osteoporotic fracture. Fragility fractures are a diagnostic of osteoporosis, as we discussed. Humeral fractures are associated with significant morbidity and mortality. Malnutrition certainly is associated with demineralization of bone, but also, as Ron had pointed out, multiple vitamin deficiency states, especially B12, folate, etc., proprioceptive disorders, muscle weakness due to vitamin D deficiency of a severe nature, if present in this patient, would all lead to increased falls risk as well. Cigarette smoking, alcohol abuse, including increased falls risk with alcohol use. So if he was at work and he fell because he was also drinking. And then excessive coffee, in other words, as an exchange for calcium per se. All right, very good, very good. So let's go on to our next case. So this is a 66-year-old patient. She has epilepsy. She has repeated falls. Her DEXA showed a T-score of minus 1.8. Her FRAX 10-year fracture probability at the hip was 1.5%, and at major site, osteoporosis site, was 12%. She's been on phenytoin for treatment of her epilepsy long term, and her basic laboratory assessment, the CBC, CMP, are normal. Serum calcium 9.1, 25-hydroxy-D 12, and intact PTH of 102 picograms per ml. So our first question is, the patient has evidence of primary hyperparathyroidism, secondary hyperparathyroidism, hypovitaminosis D. What do you think? I mean, if those in the audience are treating patients with osteoporosis, you need to click your button. You need to make a decision here, because this is not an unusual case. So the normal vitamin D level, does everyone know, it's about above 30, and because of the variability of vitamin D testing, the inter-individual variability, biologic and analytic variability, so we like to shoot for over 35. Some people like to shoot for 40, so that you are always above 30. Okay? So I just wanted to give you that. Everyone knows what a normal serum calcium level is, the range. So most individuals pick B and C. So the patient would be classified as hypovitaminosis D as a general term. Would the patient be classified as vitamin D deficient or not? What do you think? How many of you believe the patient has vitamin D deficiency? Okay, how many believe that the patient has vitamin D insufficiency? Okay, so individuals that have levels of 20 to 30 would be insufficient, and below 20 would be deficient. Okay, so just to give you some definitions that people throw around. So this patient has vitamin D deficiency, has secondary hyperparathyroidism as part of that, and has a low normal serum calcium. And we have to appreciate that serum calcium, total calcium, will be normal, maybe low normal, but still normal, because your parathyroid hormone is doing everything it can in regard to being overproduced. So your normal is about 65. So your PTH is doing everything it can to generate sufficient calcium. And so unless you have significant vitamin D deficiency, where you do not have that substrate to convert to 125 to help absorb calcium and to increase renal reabsorption of calcium and osteoclastogenesis of bone to release calcium into the circulation. When those things are so limited, then you become hypocalcemic. So you will see normal serum calciums, even with secondary hyperparathyroidism. That should be aware of that.
Can you summarize that again? You kind of lost me with all the details. So what's the bottom line on that question?
The bottom line is the patient does have...
Cause the secondary hyperparathyroidism?
The patient has vitamin D deficiency.
And that's the bottom line, which causes secondary.
The patient is not producing enough 125. The patient has developed as a compensatory mechanism increased PTH secretion. The PTH is then trying to convert more 25 to 125. It is causing a release of calcium from bone due to osteoclastogenesis, reabsorption of calcium from the kidneys, and the 125 that it's producing, trying to generate, if it has enough 25 and it's a substrate, and we're pretty close to that cut point that we talked about. And the 125 that it's trying to generate is absorbing calcium and phosphorus from the gut, if the patient's actually taking any calcium in their diet or supplements. The 125 is also helping PTH reabsorb calcium from the kidney and also has a pro-osteoclastogenesis effect on bone, independent of PTH. Okay? So it's a very complicated mechanism. Yes, please.
Do you classically order the PTH in
Yeah.
the initial workup, or do you typically order a vitamin D and a calcium, and if the calcium is abnormal, then move to a PTH?
I think my practice may be quite different than yours. So I'm only a tertiary care center. I only see patients like that. And the answer is I see patients from 100, 200, 300 miles from my center. So I have one shot at doing everything. And so I characteristically, when that patient comes back 2-3 months later or whatever to discuss their results or by phone, I want everything back. So I certainly, personally, I order a PTH. And the reason also is, as I mentioned earlier, calcium can be normal. Vitamin D, even at a level of 20, remember. So you're on that border, or 22. So you think, okay, this patient has vitamin D insufficiency, not a big deal, but the variability of testing could mean that that vitamin D level is really 16, okay, and not 22. Because of the variability of testing out there, you're not 100% sure. So I'm given one shot to figure out what's going on in that patient.
But it doesn't change your management strategy, correct? You're still going to dose vitamin D.
Yes, but it depends upon what I'm going to do to correct the whole picture. So if the patient has an elevated parathyroid hormone level, like this patient has vitamin D deficiency, I would also do a 24-hour urine for calcium and creatinine, and that's how I monitor the patient's response to therapy as well. I want to correct the mineral disorder this patient has. If the patient has osteomalacia or within the range from mild mineralization defect to all the way to osteomalacia, I want to be sure all parameters are corrected in that mineralization disorder so that I am assured that when I use an osteoporosis drug, an anti-osteoporosis drug, that the patient doesn't have a concurrent mineralization disorder and won't mineralize that bone even with zoledronic acid or denosumab, right? And that's one of the common mistakes that Ron and I see in regard to the quick pop-down menu that people use, not you guys, but other folks. Just start them on alendronate, and send them home with vitamin D and calcium, and that's all you do. And the patient continues to fracture, the bone density doesn't change. What's wrong here? What we're trying to say, what Ron and I are trying to say is, this is a complicated disease, and you have to understand bone metabolic processes and how things work to be sure that you're treating everything.
So would you want to also give her calcium because she's still on all the calcium from every other source?
Oh, yes.
Replenish that with calcium?
You're going to give appropriate levels of calcium as well. Okay? Now, this case, the following increases the risk of fractures: phenantoin therapy, hypovitaminosis D, hyperparathyroidism. And I think, one of the things that we're trying to bring up is the extent of an evaluation, a comprehensive evaluation, because that's why you're here. How do we think about things? That's why you're here. So we're available to you to try to answer and explain how we do things. So most individuals agree here, and certainly phenantoin therapy. Phenantoin is what? Right, it's an anticonvulsant. And we know that anticonvulsants per se have increased risk of osteoporosis from a variety of viewpoints or points of view that we'll talk about.
And falls.
And falls too, right. And also hyperparathyroidism as an increased risk for fractures. So very good. Now, the following medications increase risk of osteoporosis. Anticonvulsants, which phenantoin is, proton pump inhibitors, and medroxyprogesterone. Okay, very good. So anticonvulsants, so how do they cause fracture risk and increased risk of osteoporosis in general? They certainly affect the metabolism of vitamin D. So they actually increase cytochrome 450, P450 metabolism and breakdown of vitamin D active 125, as well as 25D, so at both levels. Proton pump inhibitors, the theory is that you have decreased absorption due to change in acid mix in the gastrointestinal system. Medroxyprogesterone, a direct decrease in estrogen due to central suppression. Now, medroxyprogesterone does decrease estrogen levels and is usually given worldwide, not so much in the U.S., but certainly in the worldwide community for prevention of pregnancy. And so we have suppression of bone turnover. We see decreased bone turnover with medroxyprogesterone and loss of bone mass. But usually in patients, then they go off medroxyprogesterone often and have a rebound effect, just like lactation. Has an adverse effect on bone with decreased bone mass during that time frame of lactation. As long as the patient has sufficient time to recover prior to menopause, then there will be recovery. So it also depends upon when you give medroxyprogesterone, right? So if you start out at an early teenager and they haven't modeled like a 12 or 13, 14, right after the menarche, and they don't have sufficient estrogen to model bone and to grow, maximize their bone, and they've been on medroxyprogesterone for 15 years, that's also a potential issue in developing peak bone mass. And whether they fully recover from after discontinuation of medroxyprogesterone depends upon how long, when it's instituted and how long it's continued. Yes?
Many of the pediatricians where I live are wanting their young girls in this age group not to be put on the very low dose birth control pills for the same reason. Have you heard of that?
Repeat the question.
So the question is, in your local community, the pediatricians wish to place their young...
On higher dose estrogen birth control pills.
to place their younger individuals instead of medroxyprogesterone on oral contraceptives with estrogen.
On oral contraceptives.
Yes.
But they prefer the higher dose with more estrogen.
Okay.
Than the very low dose. And they say it's for this particular reason.
Well, of course, oral contraceptives have have estrogen in them, which is protective. Now, I can't tell you. I know that lower doses of oral contraceptives, from the standpoint of having estrogen, is protective. How much versus high dose? There could be a dose effect. I don't use it, so I don't have an answer for you specifically regarding that. Anyone else in the community here have any other responses?
The doses of estrogen now range from 10 in the super low doses, 35, which is about the max you can get. I don't know that the big difference in the average 20 and 35.
Yeah. I mean, Yeah, I really don't have the expertise to respond to that. Okay, the following medications increase the risk of falls: hypnotics, hypotensive, psychotropics. What do you think? So most individuals agree that all three agents are associated, and I think both of us agree with this. There is increased falls risk with sedatives and hypnotics. Orthostatic hypotension is not uncommon, and certainly psychotropics are associated. So the take-home message is diseases increasing the risk of falls also increase the risk of fractures, and medication-induced unsteadiness increases the risk of falls and fractures as well.
Patient, somebody that you would put on bisphosphonate or something?
The previous patient that we talked about who has epilepsy and has a T-score of minus 1.8 and has a 10-year probability in the moderate range, I would correct all mineral imbalances first. Okay? So this last patient has secondary hyperparathyroidism and vitamin D deficiency, and they need to be corrected. The mineral disorder needs to be corrected first. The question is, what would be their response to therapy so that they were falling? You have to correct everything that the patient has prior to institution of a bisphosphonate. They have a mineralization disorder, as we talked about. So no, I would not place them on a bisphosphonate at this time. Okay? What you would do is you would correct the mineralization disorder, improve their falls, decrease their falls by changing their vitamin D status. You check B12, you check whatever you have to do. You get them into a physical medicine and weight-bearing program. You do a repeat bone density after they've corrected and given sufficient time, knowing the LSC at your bone density testing center to see a change. So there's no emergency based on the patient's osteopenia and having moderate risk. So this patient has moderate risk based on fractures. The patient has osteopenia but is not at high risk. The patient has a mineralization disorder. The patient has underlying metabolic bone disease. No, I would not place this patient on a bisphosphonate. I would correct the mineral disorder, metabolic bone disease, observe and make sure that PTH and 24-hour urine is corrected, and then repeat the bone density test and see if they've responded and have had an improvement in DEXA. Ron?
I agree entirely. One observation too is that if you start her on a bisphosphonate, chances are very high that she will complain of generalized aches and pains and localized bone tenderness. And the reason being, because of the increased parathyroid hormone, there are pockets throughout the skeleton with localized areas of bone resorption. And these pockets have an increased vascularity. When you give the bisphosphonate, it tends to go to the bones and tends to be deposited in the areas of excessive vascularity, and this may induce a local inflammatory reaction, and the patient develops aches and pains and bone tenderness. That patient will stop taking the bisphosphonate, and you'll have a lot of difficulties trying to restart the bisphosphonate later on. So the point Sandy was making is terribly important. Patient like this, fracture risk is not terribly elevated. The first thing, correct the deficiency. Correct the vitamin D. Did we move to another one?
Yeah, this is another.
Correct the vitamin D deficiency. And then after that, reevaluate the patient for fracture risk. Chances are very high in this particular patient that once the vitamin D is corrected, everything else will fall into place. And she may not even need treatment for osteopenia or low bone mineral density. Other thing to remember is that with secondary hyperparathyroidism, it may take up to a year for the serum PTH to come down to normal.
So your mineralization defect doesn't correct overnight. And that's a key issue. And in this patient, you would potentially do a bone-specific alk phos as well to monitor their response of mineralization and their turnover. But to place them on a bisphosphonate, as I think both of us have mentioned, would be a no-no because you're decreasing bone remodeling. Remember, there's a coupling of osteoclastic and osteoblastic remodeling. You're cutting off, you're decreasing osteoclastic bone resorption, but you're also decreasing osteoblast bone osteoid and mineralization as well. And if you do both at the same time you're trying to correct a mineralization disorder, it doesn't work. And you will not see benefit. And this is one of the most common things I see in my practice. The patient is given extra vitamin D, they take it for a short period of time, they're done with it, they think this is the end of it, and they take their bisphosphonate, they still fracture. They do not have osteoporosis. And the bone density, by the way, just a key issue, does not distinguish between osteomalacia and osteoporosis.
Could you elaborate on how you use the DASP to monitor the correction?
Well, I use all biochemical parameters that I can to be sure. As Ron said, it may take a year, it takes sometimes longer for the mineralization disorder to correct based on what the underlying disorder is, whether it's mild, moderate, or severe. I use BSAPs to determine, like alkaline phos, whether the patient may have mild osteomalacia or severe osteomalacia as part of the secondary hyperparathyroidism, the severe vitamin D deficiency, and the lack of calcium incorporation in the mineral of bone. So what happens is with osteomalacia, you actually have a correction of these laboratory parameters, unless the patient is fractured, and then fracture in itself can increase bone-specific alk phos.
Sorry. No. I was going to say that's one of the reasons why assaying the serum PTH level is so important, not only for tertiary care, but even for primary care providers, because if your patient is has a low vitamin D level and has a high parathyroid level, you're going to treat her differently than if she had low vitamin D and the PTH is within the normal range.
Again, the patient has an underlying mineral disorder.
Right.
Okay. All right. So let's go on to our next case. This is a 65-year-old female, has a screening DEXA, minus 2.8 T-score, treated for depression for about 5 years. No specific complaints, but has easy fatigability, feels lethargic, she just doesn't feel right. And this is about 5 years of depression. Finds it difficult to fall asleep, remain asleep, that sounds like me, at least in the last couple of days. Yeah. Generalized aches, pains, no definite precipitating or relieving factors. Her serum calcium is 11.2. Normal albumin, 25D is normal at 35 nanograms per ml. Normal calcium, we don't have it here, but I would presume it's around 10.2.
It's 11.2.
Oh, no, normal.
Oh, no.
We'll say 10.2. So the patient's one above the normal, 1 milligram per deciliter above the normal range. So what is her likely diagnosis? Primary hyperparathyroidism, secondary hyperparathyroidism, malignancy-associated hypercalcemia, and this is a general term for all the types of malignancy-associated hypercalcemia. There are different types of malignancy-associated hypercalcemia. What do you think? Remember, you see osteoporosis patients. Here's a patient who walks in the office or your clinic. So we have about 19 individuals entering their data. So one of the questions is, could this be malignancy-associated hypercalcemia? That's what people believe, at least a number of you believe. And this would not be, because these symptoms have been going on for 5 years. The most common cause of hypercalcemia in the community-acquired hypercalcemia, is primary hypercalcemia. Primary hyperparathyroidism. Secondary, a number of you think that maybe this is secondary, but secondary hyperparathyroidism doesn't have hypercalcemia associated with it. So in secondary, it's driven by hypocalcemia as one of the causes, you might say. In CKD, it's a different cause beside hypocalcemia. So in this case, we would choose primary hyperparathyroidism. The following laboratory tests are recommended at this stage. What do you think? Well, we got 2 folks.
It's a trick question.
Ron says this is a trick question. Okay, so A and C. So most people believe A and C. So serum PTH, well, I think most people would want PTH, right, as a confirmatory diagnosis of primary hyperparathyroidism with elevated serum calcium. Serum chloride, do you want a serum chloride? So I don't think this is essential for your diagnosis. Serum phosphorus, that certainly you could use that because we know with primary hyperparathyroidism this affects phosphorus levels and can be confirmatory. Okay? It's just the opposite. So in primary hyperparathyroidism you have a reabsorption of calcium as well, but you have a release of phosphorus. So serum phosphoruses are usually low normal or below normal in this category, depending upon the severity of the primary hyperparathyroidism. Given the serum PTH is 235, and we'll say the normal 65, and the serum calcium is 11.2, the likely diagnosis is So again, individuals that walk into your clinic have these symptoms of hypercalcemia potentially for 5 years, don't feel well. This patient has many of the stigmata of longstanding hypercalcemia, and over this extended time in an outpatient setting, the primary diagnosis or most reasonable diagnosis would be primary hyperparathyroidism. That's how I would diagnose this patient. Ron, any issues? Okay. The following laboratory tests are recommended at this stage: 24-hour urine calcium, sodium, and creatinine, 24-hour urine NTX, CTX, fasting NTX, and serum CTX, or urinary CTX, fasting A, B, or C, none of the above. All right. Okay, so most folks believe that a 24-hour urine calcium and creatinine, and you do a sodium to correct the calcium for these sodium excretion in that patient, is appropriate. And certainly if you're thinking that this patient may have primary hyperparathyroidism versus familial hypocalcuric hypercalcemia, That's one of in the differential diagnosis of hypercalcemia. You could certainly do this. You would expect to see reabsorption of calcium, although in high filtering of calcium and hypercalcemia, you actually see increased 24-hour urine calcium in primary hyperparathyroidism. If the normal, like in our lab, is 10.7, not 10.2, the patient is not symptomatic, that would be considered asymptomatic primary hyperparathyroidism. And there are certain criteria that we're going to discuss as part of that. And so you would need a 24-hour urine calcium to determine whether the patient meets the international criteria for surgical intervention versus not. Okay? So this would be an essential feature of your workup for that as well. If the patient is symptomatic, the patient has very elevated serum calciums, then it is not absolutely essential. If the patient is unsure of whether surgery would be considered, then you would do this and certainly evaluate potential other organ system involvement associated with primary hyperparathyroidism. So the following tests are recommended at this stage. What else would you consider? Would you do a serum protein electrophoresis, UPEP, folate, or none of these? So we have 3 for serum protein electrophoresis, 2 with A or B, SPEP and UPEP, and then 13 with none of the above. So in fact, the patient does have a biochemical diagnosis of primary hyperparathyroidism. So you do not have to do SPEP and UPEP to make that diagnosis. Okay? And so you do not necessarily have to do a serum folate level unless you believe the patient has anemia or folate deficiency independent of this. All right. So the following imaging studies are recommended at this stage. Sestamibi scan, CT of the thyroid and parathyroid, ultrasound of the parathyroid glands. What do you think? What would you send this patient for? You could certainly ask the surgeon to do this, so you would send the patient potentially to an endocrine surgeon or a really excellent ENT surgeon to evaluate this if you're not comfortable with this. But say you're the person that is making this decision and helping the patient. All right, so we're pretty much even here with the A's. In other words, performing a Sestamibi scan. A Sestamibi scan is a radionuclide tracer that it's a immediate and delayed imaging technique to determine whether there's increased tracer activity in a potential adenoma of the parathyroid, although other types of disease involving the neck, including certain types of thyroid cancer, lymphomatous disease, et cetera, can produce a false positive Sestamibi scan. Others believe that you would do A and C, so an ultrasound of the parathyroids. So the sensitivity and specificity of using both are very good, although it doesn't distinguish necessarily ultrasound, a significant adenoma from a thyroid nodule, so you have to be very good at doing ultrasounds. And then some people actually do CT scans. It's called 4D CT scans with a tracer, vascular tracer at the same time, like iodine tracer or other types of tracers with CT of the neck to localize a parathyroid adenoma. And this is a newer technology that radiology uses to help distinguish different abnormalities in the neck, including in people that have had prior surgical interventions.
So what was the take-home?
The take-home message is,
Which one would you do?
I would do a sestamibi scan of the neck.
Bottom line. Got it.
Yeah, absolutely. Now, if you don't have a sestamibi near you and the patient has to travel a great distance, then you could certainly do an ultrasound of the neck as well. But you have to be sure that who is ever doing the sestamibi and or ultrasound or 4D-CT know what they're doing, because these are very sophisticated tests. And also the newer technique is to combine SPEC, CT, with sestamibi for improved localization. We also know that there are select individuals, although 87% or so have a single adenoma, there are others that have two adenomas, so they have multiple adenomas. Some are not within the neck, they could be in the chest as well. And there can be hyperplasia, and the sestamibis are negative. So in very small adenomas or hyperplasia of the parathyroids, the sestamibi will be negative, the ultrasound will be negative, so all your testing is negative, and sometimes the surgeons have to go in and explore the neck to actually determine where the abnormality is.
I think it's very worthwhile sending the patient to a center where they do a lot of parathyroid imaging. Otherwise, I see this quite frequently. The patient is sent to the local hospital, they do a sestamibi scan, it comes back, no abnormal findings, and then a couple of years later, we find that they have missed something. So if you're not very confident about the center, it pays to refer the patient to a center where they have a lot of expertise doing parathyroid imaging. And now there are so many different permutations that are able really to localize it. The fear is that if you send the patient to a local hospital where they haven't got a lot of experience, the report is going to come back normal, and then you'll have difficulties doing anything at all about it.
All right. So, the CT, sestamibi with CT SPEC, the SPEC portion of that, sestamibi with SPEC, the SPEC portion is like $700,000 for that aspect. So local hospitals do not necessarily have the funds to support an occasional SPEC program, a SPEC addition to sestamibi. So that would be the best case scenario, using both together.
And it certainly is useful to do it because, as you'll see in a few minutes, the outcome of surgery is usually very good. It's almost a life-changing event, so it is worthwhile pursuing this.
So the patient, the parathyroid scan, the sestamibi shows a possible left lower lobe adenoma, and the management options include send the patient to a specialist in surgery, meaning not a general surgeon that doesn't do parathyroid adenoma surgery or thyroid surgery. You have to, or you should be sending the patient to someone that really does quite a number of these. Or prescribe bisphosphonate, prescribe denosumab, raloxifene. And I think everyone has the message here. So you want an expert to do this because of the potential complications, because we see patients who have had previous surgery for this, who have not had the parathyroid adenoma localized and removed. There is less than 1% of these individuals with parathyroid carcinoma, and if that is present, you want to get it the first time out, because otherwise it spreads locally and the cure rate then diminishes dramatically. Okay? So that's a major issue for that. The prognosis after parathyroidectomy, excellent. Serum biochemistry is normalized, but patient symptomatology does not change. Most patients need medication for osteoporosis. Many patients require surgical revision. Later, most patients develop some complications of surgery, including recurrent laryngeal nerve injury. What do you think? So almost everyone here agrees. So yes, and in almost all cases, patients feel dramatically improved when their hypercalcemia is corrected. The classical clinical manifestations of primary hyperparathyroidism include which one of these? Generalized aches and pain, renal calculi, hyperacidity, and upper GI adverse effects. What do you think? So almost everyone believes that the generalized aches and pains, and yet certainly we see that. Renal calculi, it is not as common as it used to be, but in the new criteria for asymptomatic primary hyperparathyroidism, which has changed recently as compared to just a few years back, a 24-hour urine calcium is desired, and anyone with a calcium of 400 or over should have a renal stone risk analysis where you do a 24-hour urine calcium for potential stone accrual. And if those individuals have increased risk for stone accrual, even if they don't have nephrolithiasis, this would be a potential indication for surgery, even if they're asymptomatic and have primary hyperparathyroidism. And so this is new. This is new. And then some people would do an ultrasound of the kidneys or CT of the kidneys to make sure that the patient doesn't have asymptomatic nephrolithiasis or nephrocalcinosis. So this is a new criteria in the latest guidelines. Hyperacidity, of course, this sometimes happens. Pancreatitis occasionally, not as often as people have seen in the past, but certainly it is multifactorial. Yes?
One question, but two parts. Is it absolutely necessary to do the localizing studies? I was trained 30 years ago, to find a surgeon and not necessarily have to do that. The second thing is it just the high calcium toxicity, or is it the parathyroid hormone itself that causes the malaise, fatigue, and asthenia?
First of all, you're correct. If you're not comfortable doing all these studies, you just make sure you send the patient to a good, really good parathyroid surgeon, meaning ENT or endocrine surgeon.
Well, what do you do in your group, either one of you? I mean, do you routinely, regardless since you have parathyroid surgeons anyway, do you routinely do localizing studies? And also, do you evaluate either one, especially you as an endocrinologist, for MEA before you send them?
I didn't hear it.
So do you send, so the question, Ron, is do you evaluate your patients with sestamibbe scans, ultrasounds of the neck, or CT 4D, or do you send your patients with a biochemical diagnosis of primary hyperparathyroidism to your surgeon?
Well, again, my practice is not a typical general practice. It is, we tend to see mostly patients with metabolic bone diseases, so we tend to do most of the workup. But we've got a good relationship with our surgeons, and once an adenoma is localized, then it is a joint effort between the two of us. You need a good parathyroid surgeon. If you don't feel confident, as Sandy was saying, in investigating these patients, it's much better to refer them to a center where they do these tests routinely, because if you start doing and you miss something or the results are not are not good, the patient, to reinvestigate the patient is going to be a big hurdle, because the insurance would probably not reimburse for a couple of sestamibbe scans. So if you can do it and you're confident in your radiology department and imaging studies and your interpretation, by all means go ahead and do it. I would have thought that the majority of primary care providers, once they identify that the patient may have hyperparathyroidism primary, not secondary, the easiest would be either to refer the patient to a center or to a surgeon with expertise in parathyroidectomies.
And in my case, it depends upon whether the patient has asymptomatic primary hyperparathyroidism, because there are certain criteria, as I briefly alluded to, that you would not necessarily consider surgery at that time. And in other cases where it's definitive biochemically, and I know the surgeon wants a sestamib, I would order the sestamib with CT if I had it, and then have them, and I know the surgeons like to do their own ultrasound because they're very good at that. I let them do that as well because they want to localize this as much as they can prior to surgical intervention. Does that answer your question?
Part of it. What do you think about, because we see people with malaise, fatigue, all this stuff, and they're sent for parathyroidectomy, and they're coming back with fatigue, malaise, and that's
right.
Some of these people are just, I've had 3 last week with primary hyperparathyroidism. I'm an endocrinologist, and 2 of the 3 want to go to Tampa.
Oh, yes.
So they got the mill down there. And I do all localized studies, but even my mom had hyperparathyroidism. And I think part of the fatigue malaise, maybe as an endocrinologist, my question to you is, parathyroid PTH itself, do you think that has some systemic or somatic problem, or is it just the high calcium toxicity?
I think it's the calcium primarily, but I agree with you that there are individuals that have underlying fatigue and malaise or other for other reasons. So you have to look into that, or they may be depressed for other reasons. There's a whole bunch of etiologies for that. And if you correct it, like your mom had I presume a parathyroidectomy and was corrected and she still had symptoms, it may be because her son...
Actually, Martha Zeiger did her at Hopkins, because I'm from Baltimore originally.
Sure.
The next day, the majority of my patients for like 30 years with parathyroid tumors, within 48 hours...
Yeah, they're feeling better.
Muscle strength improves and sense of well-being improves.
Right. But there may be other reasons. That's what I'm saying, if they don't improve. So I agree with you completely. Okay.
Could you repeat that new criteria that you just went over?
Oh, okay. So the question is the new criteria for asymptomatic primary hyperparathyroidism. So the criteria is about the same for individuals less than 50, those individuals that have GFRs less than 60, calcium's over 1 above the upper limit of normal at your laboratory. The urine, though, before you didn't have to do a 24-hour urine, so calcium, the most recent, the one just prior to this, the guidelines, you did not, they did not include that, but now it's over 400 milligrams per 24-hour collection, and then you would consider a urine stone risk analysis with that, and potentially either a CT or ultrasound of the kidneys to make sure the patient doesn't have asymptomatic nephrolithiasis or nephrocalcinosis, and if they do, that's an indication right there. Also, the criteria for osteoporosis has changed in the new guidelines. So in the past, it was having an osteoporosis by bone density testing, T-minus 2.5 at any site. That has continued. That's the same. But the new criteria is vertebral fracture. And so vertebral fracture is the new criteria, not generalized fractures, fragility fractures. And it is suggested by the task force that put this together, John Belzikian and his group, and not his group, but the group that came together to publish this data recently. They suggested, depending upon whether the patient has historical height loss, prospective height loss, and things like that, which would be a definite indication for imaging of the spine, you do imaging. So you do a VFA at the time of bone density testing, which is part of your workup for asymptomatic primary hyperparathyroidism. And if the patient has a fracture there that no one had diagnosed, that's an indication for surgical intervention in a patient with asymptomatic primary hyperparathyroidism. Did I answer your question? Okay. All right. So primary hyperparathyroidism is more common in men than women. Affect about 1 in 500 of the general adult population. Most patients have multiple benign parathyroid adenomas. What do you think? So we're pretty equal here. We have, well, we're still moving. So we have equal, about half believe, not quite half believe that 1 in 500 in the general adult population have primary hyperparathyroidism, and the other half believe that all are true. So I think most of us in the field believe that B is the correct answer. It is much more common in women than men, and it is usually a single adenoma in about 80-some percent, 87%. There are some that have a multiple adenoma, some have ectopic, some have supernumerary, so they have more than 4 glands, and the 5th or 6th gland is ectopic too, so you have to be careful about that. And less than one, and some of those that have this condition also have hyperplasia, not an adenoma, and then less than 1% have primary, parathyroid carcinoma. So this is a common disorder. This is very common. The following laboratory tests are useful to distinguish primary versus secondary hyperparathyroidism. 25D, 24-hour urine calcium, serum markers of bone resorption, A, B, and C, or A and C. So everybody's going for A, B, and C. So 25D, so certainly as we chatted about things, this is very useful because certainly in a patient that has low 25D, elevated PTH, that's a possibility. But we also know in primary hyperparathyroidism, 25D levels are usually diminished because of the increased conversion driven by PTH of 25 to 125 through 1-alpha hydroxylase. So it's characteristic that in primary hyperparathyroidism we see diminished 25D levels. 24-hour urine calcium. Certainly if you wish and you're not sure, you don't have any previous serum calciums and you want to distinguish primary hyperparathyroidism from other types of primary hyperparathyroidism, that would be useful. Excluding this primary versus secondary, you would potentially see low 24-hour urine calciums in secondary because you're trying to conserve calcium as much as possible in secondary. Biochemical markers of bone resorption, would they be elevated in primary? Yes, because you're having bone resorption due to PTH. Is it also present in secondary? Yes, because you're having resorption of bone as well in secondary hyperparathyroidism. Because in both situations, you have increased osteoclastic resorption of bone. One is a secondary phenomena, one is a primary phenomena, but the result is increased calcium release from bone from osteoclastic activity. In primary hyperparathyroidism, cortical bone is affected more than trabecular. Fracture risk is significantly higher than in patients with similar T-scores and no hyperparathyroidism. And the pattern of bone loss is an accelerated form of that seen in osteoporosis. What do you think? So I think most folks believe all three. Okay, what do you think, Ron? You wrote this question. So cortical bone is affected greater than trabecular bone?
Agreed.
Agreed. So this is characteristic, and this is one of the conditions that you would wish to order a forearm bone density test. Because we know that the 33% or one-third site of bone density testing is primarily cortical bone, about 90% cortical bone. It has also been shown recently in the same international consensus of primary asymptomatic primary hyperparathyroidism that PQCT is a very useful test looking at trabecular bone and cortical bone at the wrist, at the ultradistal sites. So we actually see with more exacting measurement techniques trabecular bone loss too, and select individuals also have trabecular bone loss, so it's not always one or the other. Fracture risk is significantly higher than in patients with similar T-scores and no hyperparathyroidism. Okay. Pattern of bone loss is accelerated from other types. Okay, so this is characteristic. You have increased bone loss independent of or synergistic or complementary to postmenopausal bone loss, age-related bone loss, which is approximately 1% per year. With primary hyperparathyroidism, though, there's a long latent period usually for diagnosis. It can be very many years. And John Balzekian's group looked at this and reviewed patients over 15 years with primary hyperparathyroidism and found that it took, in some cases, 10 years to see a significant decrease in bone mass in their patients. So it's variable. But he's had a very small number of patients. There were like 15 patients only that they were followed that long. Indications for parathyroidectomy. What do you think? So I think most folks believe that all three are, and certainly in those individuals that are symptomatic, they have very elevated serum calciums, they should be considered for surgical intervention. In asymptomatic primary hyperparathyroidism, we use these criteria and the newer criteria that I mentioned to you as well. Prognosis, most patients sustain multiple fractures in untreated patients. Most patients go into renal failure. Most patients develop multiple kidney stones, not clear, all of them or not clearly defined. What do you think? So we have 9 individuals that believe all of these, and then about 5 believe it's not clearly defined. What do you think, Ron? How would you vote for this?
Let me have a look at my notes.
Okay.
E, I went.
So Ron believes that it's not clearly defined. And as I mentioned to you, Dr. Balzekian, John Balzekian, followed patients for 15 years. Those patients did not have surgery and found that there was variability in fracture rates and bone loss in that patient population. Certainly they don't all go on to renal failure, and a majority do not have renal calculi. So I believe that it is not clearly defined. I agree with Ron entirely. Normal calcemic primary hyperparathyroidism. PTH is elevated, calcium is normal. This is normal calcemic primary hyperparathyroidism. So this is a tricky one, right? Yeah, try to trick us. PTH is elevated, calcium is normal, 25D is normal. What do you think? So there are individuals that have normal calcium primary hyperparathyroidism. All right. So the majority believe all three are present. Okay. So yes, parathyroid hormone is elevated in these patients. Calcium is normal because you have that diagnosis, normal calcemic, obviously. Just want to be sure we're all on the same page, right, Ron? Okay. And then 25D is normal too. So it's very interesting in primary hyperparathyroidism. Those individuals who have absolutely normal 25D levels have lower than expected PTH levels too. It seems like there's an independent suppressive effect of 25D, not 125D, but 25D on PTH. It's very interesting. And when you correct it, this is what we see. In those that have primary hyperparathyroidism, as I mentioned earlier, it's characteristically to have low 25D. This is very mild disease, and your calcium has not become abnormal as long as you've corrected for your serum albumin. Okay? So, and by the way, after parathyroidectomy, even without treating the patient with vitamin D, 25D levels correct in many of these individuals or improve dramatically. Surgical management, relatively simple, safe, results are reduced bone turnover, increased BMD, results reduced fracture risk and resolution of biochemical abnormalities. What do you think?
How much? Okay.
All right, the majority of individuals here believe it's A, B, C, and I think we would agree that the biochemical abnormality, first of all, done in excellent hands. It's not a difficult procedure, okay, but it can be, there can be adverse reactions if not done in good hands. Results, certainly bone turnover is totally changed. You have a correction, and certainly there's reduced fracture risk. Biochemical change occurs rapidly, and in these patients we would watch them. We would repeat their bone density 2 years later, or 1 or 2 years later, depending upon the situation, to see recovery. Calcimimetics are useful in patients with hyperparathyroidism who are not able to or refuse surgical intervention. Increase the sensitivity of calcium sensing receptors on the parathyroid gland, should not be administered to patients with creatinine clearance of less than 35. What do you think?
I would skip the take-home messages because you've got vitamin D and steroid issues. Okay.
So those that are voting believe that all of these are correct. And calcimimetics are different than bisphosphonates. Okay? So you can provide these to patients with 35 milliliters creatinine clearance or less. There is increased sensitivity, so there is response of the parathyroids and decreased PTH production. There is suppression in patients with primary hyperparathyroidism. It's useful in people that have primary hyperparathyroidism who are unable to have surgery. And so we use it. And there's recent literature to show, following BMD in these patients, that it may be there may be suppression of the effect of PTH on bone and some reversal or decreased progression.
Is a calcium-medic just a calcium supplement?
No. That's like Sensipar or Cinacalcid, as it's called. It's a specific, yes, it sets the calcium sensing receptor at a different threshold. And basically it is then saying to the calcium sensing receptor, suppress more, suppress PTH production. That's what it's doing. So these are not calcium. This is not calcium. It's a calcium sensing receptor modulator. Okay. Conservative management, restricting calcium is useful in primary hyperparathyroidism. Estrogen in women, anti-resorptive therapy. What do you think? So a patient, can't have surgery. The patient's not able to have surgery. What would you do? You want to preserve bone mass. You want to do something. Will restricting calcium intake make a difference in hypercalcemia associated with primary hyperparathyroidism? I think what we're trying to do here is say this is very sophisticated disease processes. And if you're going to treat these individuals, you have to understand how to do this. And this is really important. So most people take anti-resorptive medications. Some believe that it's B and C estrogen in women have been shown to decrease resorption of bone. And only 2 believe that restricting calcium is reasonable. So in fact, we do not restrict calcium because that's not the cause of the hypercalcemia in primary hyperparathyroidism. And so the committee or task force suggests 500 to 1,000 milligrams of total calcium a day because you have to supply calcium in these patients as well, and that is not the cause of hypercalcemia. There are very few conditions in which there is hypercalcemia that would respond to decreased calcium and vitamin D intake, and that would be in those patients that have hypervitaminosis D, where you'd want to decrease calcium intake and vitamin D intake because that's one of the drivers of that condition. I mean, that's not the driver, but that's the fuel. Estrogen has been shown, as well as anti-resorptive agents, in decreasing bone resorption in these patients. So yes, you can use these agents. In most cases, we would use bisphosphonates, or denosumab has been used in some patients too. Now, we're not talking about FDA-approved trials, though. Take-home message. We're going to go on here. These are criteria. This is in your handout. So let's move ahead to our next patient, case 5. Okay. And this is a 68-year-old asymptomatic female, T-score minus 2.2 at the femoral neck, fracs 2%, and that's at hip, and at major osteoporosis sites, 15%. Frequent falls. The patient has cervical spondylosis and vertebral basilar insufficiency associated with it. Orthostatic hypotension, so the patient has a significant drop, as you can see here, in systolic and diastolic blood pressure on standing. The get up and go test, also called the TUG, completed in 19 seconds, which is excessive. DEXA scan, lowest T-score at the femur neck, minus 2.2. Labs are normal. Family history, negative for osteoporosis. As you can see here, Frax is 2 and 15%, calcium 9.2, albumin normal, 25D low, PTH elevated, 65 is normal. Given the routine laboratory tests, the likely diagnosis is what do you think? So I think most people believe A and C. So as we talked about, the patient has vitamin D deficiency, has low normal calcium, so normal would be, I don't know, in this lab it's probably 8.8, 8.9, something like that, so it's low normal serum calcium. So it's most likely secondary hyperparathyroidism associated with this condition. Let's continue on. At this stage, the following laboratory tests are recommended. What would you consider doing in this patient? All right, we have an interesting split here. None of the above. The majority believe serum magnesium, and some believe a 125D level. So one thing you do not necessarily have to do a 125D level in secondary hyperparathyroidism. Magnesium is also always useful in these cases, and we commonly do that because of the suppressive effect and increased resistance to PTH, and if the patient has malabsorptive syndromes or all the other causes of hypomagnesemia, you'd want to correct this also as you correct calcium and vitamin D deficiency. There's no point at this point in time to do a serum CTX or chloride. At this stage, following laboratory tests would be recommended. 24-hour urine calcium, sodium creatinine, 24-hour markers for bone resorption, fasting serum markers of bone resorption, A, B, or C. What do you think? So most individuals have picked 24-hour urine calcium, sodium, and creatinine. And as we talked about in secondary, very significant secondary hyperparathyroidism, you would expect low, very low urinary calcium. And of course, you could use that as a corrective process to monitor your patients over a period of time. There is no necessity to do these other laboratory tests at this point.
Question, why do you need the sodium with the 24-hour urine for calcium and creatinine?
Well, because we know in the American diet there's excessive amounts of sodium. And sodium excretion pulls calcium with it. And so if you had like 200 you had excessive amounts of sodium, you'd have to correct the calcium for that sodium because we know that the sodium is pulling it. So you have two choices. You can send the patient home and say, we're going to do your 24-hour urine, but don't add any sodium to your diet, and determine that. Or you could be more precise and look at the sodium excretion and then correct it for correct your 24-hour urine calcium for the sodium. So every milligram or so of sodium then has to be corrected for calcium. Is that what you do?
Yeah.
Okay. I just had a patient in who was on a very high sodium intake. And so I just said for a couple of weeks, I want you off of all your sodium. And we'll see what her 24-hour urine calcium is. So yes, it does make a difference. Average diet without adding salt to our diets, about 60 milligrams of urinary calcium is associated with the sodium in our foods. And if you add sodium to your food as well at the table, you're adding at least another 60 plus of that calcium as part of the sodium load. So it could be up to 120 or more milligrams of your 24-hour urine calcium is just from sodium and very high salt diets. So the patient, you'd have to correct for that if you really want to know the excretion. Or you just have the patient decrease their intake during that period of time prior to their 24-hour test. Yes, please.
What are you going to change once you get back to 24-hour urine? I'm not clear on that. What's it going to make you do differently?
Ron, how would you use the 24-hour urine calcium in this case?
A lot will depend on the sodium. If we find that the sodium is very high and the calcium is high, the first thing is to tell the patient to restrict the sodium intake. If you find that the sodium is normal and the calcium is up, then you're looking at hypercalciuria and the various causes of hypercalciuria, including hyperparathyroidism. So the sodium is really essential to help you guide which direction do I go. Do I just tell the patient to cut her sodium intake, or do I remove the thiazide diuretics or the loop diuretic she's on, or do I start looking for causes of hypercalciuria?
But in this case of secondary hyperparathyroidism, how would you use this? Are you going to use this in any specific way?
No, just to know how much calcium she's losing and whether it is due to the excessive sodium intake. Again, the food we're eating is, I want to say, almost saturated with sodium, and there are a couple of questions coming up later about the effect of sodium, which food contain a lot of sodium. Most preserved food contain a very large quantity of sodium, and we are not even aware of it. Soda drinks contain quite a lot of sodium. That's why they call them soda drinks. So I don't know about you, Sandy, but I rarely do calcium in the urine without looking at the sodium at the same time.
No, I also do that. I think what you're asking, though, is a little bit different. Okay, how would it change your therapy? And what Ron is saying, and what we do, is we want to correct any disturbance, including excessive loss of calcium through the kidneys, so that you have adequate reabsorption of calcium as part of your treatment and a restoration of mineralization of bone. Does that answer your question? In addition, as mentioned earlier, I'm very compulsive and maybe excessive. Well, my wife says that sometimes. And so I use many parameters to be sure that I've corrected the mineralization disorder. So I use many different tests to help me with my patient. And then, as Ron had mentioned, what if the patient, you correct all this, and the patient still is spilling a huge amount of calcium? So the patient actually has hypercalciuria independent of secondary hyperparathyroidism that you've corrected, which is another etiology for bone loss. Okay, so you want to correct that, because about 10 to 15% of the population have idiopathic hypercalciuria.
And if your patient is losing a lot of sodium and calcium at the same time, a thiazide diuretic would be quite useful. It would, as opposed to a loop diuretic.
Yes, please.
So what instructions do you specifically give the patient about limiting their sodium, and for how long before you do a correction?
So the question is, how do I, what, yes, so has everyone heard that?
Repeat it, please.
So the question is, how long before we do the collection do we restrict sodium? How long do you suggest to your patients?
I personally do it for at least 1 week.
Okay.
And what do you give them? How much sodium are you telling them to have in their diet?
I suggest no added sodium, so they're not salting their food. Because we all know that in the American diet per se, it's very high in sodium. If they're eating a lot of preserved meats and things like that, canned foods, and are drinking soda, then the real issue is how much of their dietary regimen is driving the hypercalciuria and how much can you correct it. And so the real issue, the basic issue that Ron is bringing up is, can you correct hypercalciuria driven by diet? By changing the patient's intrinsic dietary patterns, which are going to be better for them anyhow, because these dietary regimens have other adverse issues.
A major source of sodium is also nuts. Many people eat nuts, whether it's peanuts or almonds or whatever it is. They're literally full of sodium unless they're unsalted.
Do you also give them a specific amount of calcium to take during that week so that they're not taking 2,000 milligrams of calcium in their diet?
So the question is, do you limit the calcium intake or you don't bother with the calcium intake when you do that, if they're taking supplemental calcium?
Well, it's better to get calcium from food rather than supplements. But no, I wouldn't limit the calcium intake. If anything, you want to encourage them to get at least their expected calcium intake from food. Supplements, it's a different matter.
And I think that I would concur and say, when you're concerned about hypercalciuria, how does the body, and we're not talking about secondary hyperparathyroidism now. We're saying we want to be sure the patient doesn't have idiopathic hypercalciuria. Then I would say, and we know that if you take in extra doses or too much, I've seen patients with 3,000 milligrams of calcium supplement per day. And where do you think you're going to spill that? Of course. So in those cases, what I do is discontinue all supplements. Okay.
The other thing you may want to consider also is discontinuing or reducing the intake of red meat, because again, the red meat would increase the amount of sodium and calcium going into the urine, even if the red meat itself is unsalted.
Okay.
So just to clarify that point, if you limit their sodium before they get their 24-hour urine, it'll make your true test of the calcium more
accurate.
That's what you say.
And then you can distinguish idiopathic versus, dietary induced hypercalciuria. And that's what you want to know, because if you repeat the study and it's absolutely normal, and then you know this patient has been hypercalciuric and probably negative balance or potentially negative balance for decades, this is a very useful way of explaining to the patient what has happened and to monitor them as well. So let's go on. Same case. Stage the following laboratory tests are recommended. Would you also do these studies? Any of these studies? In secondary hyperparathyroidism. Are we, time-wise, are we okay? Okay, we need to move.
Because you really want to spend time on vitamin D.
Okay.
And steroid.
So most people believe that none of the above. Do you agree?
I agree.
Okay. So let's go on. We got to move forward. At this stage, the following tests. Please vote. We're going to move forward quicker. Anybody believe any of these tests are useful? How many of you believe these tests are useful? Raise your hand. How many believe that they are not useful to you? Okay, so you have to. So there's no none.
It should be here.
Oh my God, Ron. So this is another one of Ron's trick questions.
No, my mistake. I'm sorry.
No, that's okay. All right. Management options should include cholecalciferol, 4,000 units, divided doses, ergocalciferol, 50,000 units for 12 weeks, cholecalciferol, 1,000 units a day for 1 year, cholecalciferol, 400 units daily for 1 year. What do you think? How would you treat the patient's vitamin D deficiency?
9:30. Okay.
All right, so most individuals believe that 50,000 units of D2 or D3 are appropriate for 12 weeks. That's a standardized approach here. What we also see are people that are started on this, and that's it. And we see this not infrequent, that they come to us after being provided this significant dose, and then they're not provided a maintenance dose, and that's a mistake, because the same thing will happen. Okay?
Sorry, you've got until 10.
Okay. Very good. The best indicator of serum vitamin D is, you have three choices.
This is a very important one, the vitamin D. And then the glucocorticoid. Is there anything else?
Okay, so everyone has chosen wisely, and this is 25D level as an indicator of vitamin D status. And remember, we talked a little bit earlier that 25D is in nanograms per ml, and 125 is in picograms per ml, 1,000-fold difference. So you have this large bucket of 25D, very small bucket of 125. And so this is the storage form that we're really considering in body status, because there are actually vitamin D receptors and 1-alpha-hydroxylase in almost every cell in your body. So it's required for many other functions in your body, not just calcium balance. Okay, the following is true or are true. Cholecalciferol is made in the skin or ingested. Ergocalciferol is ingested. Ergocalciferol is derived from plants. So most individuals, let's see, we're still moving ahead here. So we have 16 individuals believe all three are correct. So correct, cholecalciferol is made from a pre-vitamin D conversion. Some of my patients that cannot convert and are not able to absorb, we go through, I know it sounds strange, but we ask them to get sun tanned. We ask them to go to sun boosts, those ultraviolet boosts, to enhance conversion because they can't absorb at all due to a significant disease. Ergocalciferol is ingested, and certainly it is from initially plant sources. 25D levels reflect conversion of 7-dehydrocholesterol to cholecalciferol in the skin. The amount of cholecalciferol ingested, and the amount of ergocalciferol ingested. So when you do a 25D level, is this reflective of these different sources? All right, and certainly it is reflective in most cases. You have to look at your assay, though, because some assays will not break out D2 and D3. And in those assays, you can't be sure if you're giving the patient vitamin D2, ergocalciferol. So that's an important issue if you have a potentially non-compliant patient, and you want to be sure. The hydroxylation of vitamin D, either one, and so your 25D level, when it measures both, will be included in your printout. Vitamin D2, vitamin D3, total 25D. occurs only in the liver at 25 position to yield 25 hydroxy vitamin D. Okay. And the liver is closely regulated by serum parathyroid hormone, is affected by serum calcium. All right, we still have a few others. So we're not sure. I think that's what it says. Okay, so let's just say that where is the conversion of vitamin D, choline to 25D, and that would be in the liver, okay, as we talked about. It is not regulated by parathyroid hormone. The parathyroid hormone regulates and stimulates 125D conversion to, 1-alpha hydroxylase conversion of 25 to 125D in the tubules of the kidney. Okay. This can be affected by serum calcium, and that decreased serum calcium results in increased PTH, which increases hydroxylation of 25 to 125, as we talked about. And so that's a significant factor as well. The further hydroxylation of 25D occurs in the kidneys, regulated by serum PTH, yields 125, which is the most active component, or vitamin D metabolite, yields other hydroxy vitamin D inactive metabolites. So I believe that most individuals believe that all are correct, and I believe you are correct. So as we talked about it, the hydroxylation does occur in the tubules of the kidney driven by PTH. It certainly results in 125D, and also the metabolism of vitamin D to 124-25D occurs as part of the degradative process of 125. Okay. The main actions of 125 include increased calcium absorption through the GI tract, reduced renal calcium excretion, increased calcium mobilization from bones. A and B, A, B, and C. All right. So most people believe all three. So as we discussed, 125D certainly aids in the absorption of calcium through the GI tract. It certainly, there is evidence that it aids and assists PTH in reabsorption of calcium, and independently it has been described to increase reabsorption of calcium in the kidneys. Significant levels of 125, including hypervitaminosis D, meaning excessive 125D due to granulomatous disease, as we talked about, has been shown to increase bone resorption as well. So we know that this is one of the features of 125. It is capable of driving osteoblast rank ligand production and osteoclast formation and bone resorption. We talked about that yesterday. All right, the classification of serum vitamin D levels: normal, 30 milligrams per deciliter; insufficiency, 20 to 30 milligrams per deciliter; deficiency, less than 20 milligrams per deciliter, or all of the above. What do you think? All right, so agreed. So this is the current status of our classification system. Medications interfering with vitamin D metabolism include anticonvulsants, narcotics, glucocorticoids. What do you think? So most individuals believe that all three, and as we talked about earlier, anticonvulsants are certainly associated in a variety of different ways. We know that there are pregnein XR ligands that bind to the vitamin D receptor and drive this and are stimulated by anticonvulsants and other metabolic and other molecules. We know that glucocorticoids also drive this process and interfere with vitamin D metabolism. It's certainly known that the cytochrome P450 enzymatic breakdown occurs and decreases not only 125 but 25D. And narcotics have been also associated with the same P450 breakdown of 125 and 25D. Okay? Not all anticonvulsants work in the same fashion. Not all have been shown to have significant metabolic effect like this, but it seems like even those that are not as metabolically active in degrading 125D still have an adverse effect on bone. Clinical manifestations of vitamin D deficiency: generalized nonspecific aches and pains, muscle weakness, especially pelvic and shoulder girdle muscle, bone tenderness, all of the above, none of the above. Please choose. And the majority here believe that all of the above, and that's basically what we see. So severe vitamin D deficiency. I remember one gentleman coming in, he was in a wheelchair, could not function at all, had generalized pain, muscle weakness, and with correction, total correction of his vitamin D deficiency, he also had osteomalacia, and it took, as Ron had mentioned, at least a year for total correction. He just walked into the office without pain. It was beautiful to see this. So this is one of the occasions when it's a blessing to see a response to therapy. Foods rich in vitamin D include oily fish, fried foods from your neighborhood. I'm not going to mention any names. Dairy products, A and C, A, B, and C. All right, so most people believe oily fish. How many of you have sardines? Do you have Norwegian sardines or local sardines? Is there a difference in vitamin D content? What do you think? I have not checked, I'm asking. Okay, so yes, so dairy products are fortified in this country, but not in other countries because of fear in the UK with the previous false research that was actually published, I think it was in the 50s actually, in which vitamin D fortification caused birth defects and problems, which was false. It was undermined by the Royal Society, Royal College of Physicians in the UK, and yet it is still found on the internet. It's absolutely amazing. And it's still not fortified in the UK, correct? Do you have any comment?
Of all places, the UK, where there is so little sunshine, it's not fortified. What's very interesting, though, in the UK is that if you look at the prevalence of vitamin D deficiency, and you compare Scotland, very much in the north of England, as opposed to the south of England, Southampton in particular, there is at least twice as much incidence of hypovitaminosis D in Scotland than it is in Southampton. But still, in England, you cannot get vitamin D fortified milk. It's just milk without vitamin D.
So what is the explanation, even though they debunked officially that publication many years ago?
I think there is still concern about the possibility of developing hypervitaminosis D.
Those are your colleagues. Talk to me. All right, well, you don't have an answer, I'm sorry. Okay. Patients with hypovitaminosis D often have elevated serum PTH, resulting in secondary hyperparathyroidism. Elevated PTH level returns to normal range within a few days of correcting vitamin D deficiency. Serum calcium levels are usually low, or is usually low. What do you think? All right, so a nice spread. So first of all, yes, they certainly have elevated parathyroid hormone levels, and as we've talked about in this patient and other patients, that would be consistent with secondary hyperparathyroidism. The elevated PTH levels do not correct overnight. This takes quite some time, and mineralization of bone takes a long time, meaning mineralization of that demineralized osteoid takes some time. Serum calcium levels are usually low. They can be low normal, as we talked about. They can be in the normal range. That is not infrequent. That is characteristic. And you have to correct for calcium, though, either high or low albumin. All right, and the take-home messages, as we talked about, best indicator of vitamin D status is 25D. Dietary sources, ergo from plants or cholecalciferol. Vitamin D can be formed in the skin, so this is another source in those individuals that have severe malabsorption disease. They're hydroxylated at the 25 position in the liver, and then 125D in the kidney stimulated by parathyroid hormone in the tubules of the kidney, and 125D increases absorption of calcium in the ileum. Clinical manifestations include all the symptoms that we discussed. So this is sort of an overview of decreased serum calcium, a patient that has hypocalcemia, in which the ionized calcium is the trigger for the calcium sensing receptor in the parathyroid glands, which stimulate parathyroid production, which leads to increased osteoclastic bone resorption, release of calcium in an attempt to correct. You also have the same effect in the kidneys, driving 125D production, increasing absorption into the GI tract, and PTH reabsorption in the distal tubule, active reabsorption of calcium. We also see that then this feeds back on the loop as it's corrected. We see the UV light converting 7-dehydrocholesterol in the skin with heat to vitamin D, converted in the liver to 25D, kidneys to 125D, and then the metabolites out through the kidneys. Everybody got it? Wow. I know, it's a lot.
Is that in the handout?
No, this is not in here. We want you to memorize this, and you'll be tested post-course in about 2 weeks. No, actually, Ron says 3 months, so it gives you retention. We want to know. No, I'm just kidding.
If any of you want any of the slides, please let Mandy know, and we'll email them to you.
Okay. Yes.
Is there any reason that you would ever prefer vitamin D2 over vitamin D3?
What do you think, Ron?
The question is there any advantage vitamin D2 over vitamin D3? No, it's whichever your patient responds best. The evidence we have now is that if you give vitamin D, the increase is slower than D2, but then it is much more sustained. And it's been the experience of many people. If you give vitamin D2 or ergocalciferol, there will be a fairly quick increase, but then once you stop it, it decreases very quickly, and your patients may go back to hypovitaminosis D. If you give them vitamin D3 or cholecalciferol, the increase is much slower, but it plateaus and remains for much longer.
One thing I have seen over the years is I've never had a treatment failure with vitamin D3, even when they were very low, down 6, 7.
Right.
Within 3 months, they were always back to normal. And I've never had any kind of adverse reaction to D3, but I have seen it to D2.
Right. Well, D3 is much more physiological because it's the one that is made in the skin, ultraviolet light, as you've seen on 7-dehydrocholesterol. And there is evidence that is mounting down now that D3 gives a slightly better response. Now, we don't like to give it for more than 3 months at a time, especially if you use these doses. And it would be a good idea to repeat the vitamin D assay 3 months later. And then what I usually do, Sandy, I don't know what you do, but if I have a patient with hypovitaminosis D, now I would prefer to give cholecalciferol 2,000 twice a day for 3 months and then reevaluate the patient. If 3 months later the vitamin D level is within the normal range, I don't do anything until the following fall. And sometime in September, October, I would re-assay the vitamin D. And the reason I pick up September, October is the end of the summer period, end of exposure of the skin to ultraviolet light in sufficient quantities. If I find in September, October that the vitamin D level now has fallen, I would give back the cholecalciferol 2,000 twice a day. 3 months later, I reevaluate. If the patient has normalized, in that patient who had a dip, he went into hypovitaminosis D after being treated, I would maintain that patient on 1,000 units once a day. And every year in the fall, I would repeat the vitamin D assay. If the patient now had hypovitaminosis D, you corrected it 3 months later, and you measure the vitamin D in the fall and it's normal, you don't need to give any supplements. Did you do the same? Or?
We all do something different, you know, and I come from a different part of the United States than Ron, so I have to do something a little different. So there's a conversion formula that some of us use, and that is for every IU increase, for every nanogram per ml increase in 25D level, you would give 60 to 100 IU of D replacement. Conservative would be 60. Okay, so I look at the patient and say, okay, I've provided them with high-dose vitamin D as a supplement, but I know that they're going to need a maintenance dose long-term. And I characteristically then convert over their deficiency and then provide them with the maintenance dose when I see them in follow-up with their follow-up 25D level to assure that they're going to be on sufficient dose long-term. So we all do it a little differently. It's not wrong. It's the issue is we want to assure the patient is replete in vitamin D and does not have an underlying metabolic bone disease. Now, in individuals that have elevated serum calcium, you have suppression, as we talked about. Calcium sensing receptor is activated. You have suppression of PTH release, synthesis and release, and you have decreased PTH effect on bone, decreased 125, 1-alpha hydroxylase conversion of 25 to 125. You have decreased effect of 125 on the GI tract, and so you have a correction of the hypercalcemia if possible. In individuals that have non-PTH dependent hypercalcemia, so it's not PTH dependent, what we normally would see then is very low or undetectable PTH. And that's one way to distinguish PTH dependent versus those other potential etiologies, including cancer-associated malignancy-associated hypercalcemia. Okay, so let's go on to our last case, I believe. Pardon me?
Last but one.
Oh, yes, yes.
That's the female athlete.
Right. So this is a 38-year-old female with a left Colles fragility fracture and a Z-score of minus 2.9. She's had irregular menstrual periods since a teenager, and so this is a significant finding that we've talked about. She has had amenorrhea for the past 10 years. She vigorously exercises 2 to 3 hours a day. She feels great. She has a very poor appetite. Her weight is 92 pounds with a height of 65 inches. Her routine laboratory tests are within the normal range. So our first question is, what is the most likely diagnosis? This would be female athlete syndrome, anorexia nervosa, drug abuse, A or B, or C. All right, it's kind of split between female athletic syndrome and anorexia nervosa. So I think that this is a very interesting case, and certainly one would have to determine or think about in the female athlete syndrome whether anorexia nervosa is part of that syndrome. And it is commonly associated with that syndrome, but not all the time. So is the patient have anorexia nervosa, has bulimia nervosa as part of this, or are there separate aspects of it? Is the patient just an over-exerciser and has lost her menses because of that aspect and is not really anorectic? Of course, we know in this patient, she doesn't eat. So this is part of one of the major issues here. And she is exercising with caloric deprivation, as we say. So in a woman who exercises excessively, the female athletic triad includes amenorrhea, disordered eating, and osteoporosis. Which one or all? In the classic form. All right. So most individuals believe all three, which is correct. But it's to a different extent. And we know that questioning these individuals, and they're characteristically younger individuals, but this goes throughout their lifetime, proceeds throughout their lifetime as well. They do not actually come out and tell you they have anorexia. They just don't tell you, and you have to really dig and talk to their loved ones, their spouses, their companions, whoever it is, and really have to consider whether that is certainly part of the process. Management of the female athletic triad. Athlete triad includes restoring menstrual periods, anti-resorptive medical therapy, osteoanabolic medical therapy. What do you think? How would you treat this patient? All right. So the majority, everyone actually, believes that restoring menstrual cycling is important in the female, and that would be true. And so in these individuals, this is a caloric deprivation syndrome with hypothalamic pituitary dysfunction. I mean, how many individuals who are starving, basically, whether they're like this patient or in prison camps in the world, in the past, present, whatever, really your system, your hypothalamic pituitary gonadal axis, that shuts down. You're not in a reproductive mode during that time frame. And so this is a normal response of the body to starvational states and significant anxiety, depression, whatever. All of these issues can induce this process of amenorrhea. Certainly there's also hypercortisolemia in these cases too, which drives this abnormality in bone resorption. So you would certainly want to restore menstrual cycling as a primary concern. This is not only in women, but men that have the same. And it's even more difficult in men at times to be able to discriminate. Anti-resorptive medications only in those individuals that are like a last resort in regard to treatment. Same thing with osteoanabolics. So the take-home message is, it is the original description from the American College of Sports Medicine. It's a disordered eating issue leading to secondary amenorrhea, osteoporosis, meaning fractures. So this is a really major issue in these patients. The revised definition, not all patients have all three components. So again, anorexia nervosa may not be part of it. We see patients, I'm sure Ron does too, they have significant caloric intake, but it's not sufficient for the activity level that the patient is participating in, and they're still deficient. And so disordered eating is in 62%, the optimum to low energy availability. So they're just not keeping up with the activity. They're just burning it off. Amenorrhea, eumenorrhea, functional hypothalamic amenorrhea, we talked about that. Optimal BMD to osteoporosis. So one of the things that we are concerned about in this woman is that this continues to her menopause. And then she has had low bone density based on a lifelong history. So if this started early in life, which is very, very possible because of her irregular menstrual cycling, and she was like an early athlete in high school even, then she may never have modeled sufficient bone. She may have never have attained her peak bone mass that we talked about before. And then at the time of menopause, we have all these other problems. Even if she corrects after that, even if she eats sufficiently after the menopause, you're still left with this significant lack of peak bone mass, a loss of the genetic potential for peak bone mass that predisposes this patient to osteoporotic fracture. And that's what we talked about yesterday in regard to peak bone mass. You have to go back into the patient's history. If you see less than expected peak bone mass, average peak bone mass, remember we talked about that yesterday, to determine if the patient's menstrual history, if they were an athlete, were there other diseases, medical conditions, medical therapies that were given to the patient earlier in life that resulted in less than expected or less than average peak bone mass. And that is common. That is not uncommon. Okay. So the treatment certainly is a multidisciplinary approach. Patient education, we have psychiatry, psychology, nutrition, physical therapy, everyone working together on this. We have to decrease the energy expenditure, increase caloric intake with good nutrition, restore menstrual function. If not, then we have to consider alternatives in this case. Optimize BMD, and the last resort, if it cannot be considered as pharmacologic treatment. In some cases, it has not restored or prevented fracture. So we know that there's underlying disease process here endocrinologically that is driving this. All right.
That's the last case.
This is the last case. Okay. So I have 20 minutes. We're okay then. Okay, good. So this is our last case before our break. This is a 72-year-old male with giant cell arteritis, about to start prolonged high-dose glucocorticoid therapy, and in GCA it's not uncommon to start 60 milligrams or more of prednisone per day. He's very physically active. He's mentally in good shape, good dietary calcium and vitamin D, well-balanced diet. His routine chemistry and vitamin D are within the normal limits. His T-score is minus 1.4, and his FRAX score is 8% for major osteoporosis-related sites and 0.4% at the hip. So this would be considered low FRAX risk, low fracture risk. Given the T-score and FRAX scores, then the patient's risk of fracture is low. No need for any intervention for bone health. DEXA scan is recommended to have a baseline. DEXA scan should be repeated at a yearly interval. So we don't have a history when this DEXA was done, Ron. Was it done just before, or was this done 10 years ago?
No, it was done as part of his evaluation.
Oh, okay, so this DEXA was done at this time. So do you really want to have a repeat, another repeat? Okay. And you want to repeat DEXAs annually. So we're getting most individuals C and D.
He already has it. So.
Yeah, he already has it.
It's a trick question.
Ron said, he whispered to me, it was a trick question. So I just wanted to be sure that you know that about Ron. Okay, so most people would pick C, the DEXA scan is, and so in general, you know, if the patient didn't have a DEXA as this patient, you would certainly want to do a baseline DEXA, all right? What if the patient had osteoporosis? What if the patient had absolutely high bone density? Does that influence what you do? And certainly a DEXA scan should be repeated at annual time frame on treatment. Now, with glucocorticoids, though, you know, the issue is how often do you do bone densities? And we're going to talk a little bit about that as well. So, in regard to glucocorticoid-induced bone demineralization, is it dose-dependent, more pronounced during the first 3 months of therapy, peaks at about 6 months, and continues thereafter forever, but at a lower rate? What do you think? So everybody believes that it's all of the above. And the answer is yes. So it is dose dependent. The greater the dose, the greater the effect benefit as well as risk. It is certainly the immediate effect occurs very rapidly. So this patient is assessed early on. This is the best of all worlds. This is the best approach prior to the institution of therapy. this is when you'd want to do your bone density. This is when you'd want to intervene to prevent bone loss, not 10 years later. And that the peak effect of steroids on bone is rapid, and then you have this gradual but progressive loss of bone mass associated with chronic steroid use. Glucocorticoid-induced demineralization is more pronounced in cortical bones. Trabecular bone is best monitored by QCT of the vertebra. What do you think? So we have QCT densitometry as well. So we have a nice spread here. This is good. So we have a lot to talk about.
It's taking shape, but that's it.
Yeah, this is great. So let's see. So I think we're done here. So first of all, people do not believe, about 5 believe that it's pronounced in cortical bone primarily, and we know that from the adverse effects of bone tissue that it's primarily and early on trabecular bone loss. So we see that. So if you did a radial bone density test, a radius bone density test, you're not going to see it there first. And so it's trabecular bone that's the most prominent early on, although later on all bone is lost, including our shell, meaning the cortical shell. It is best monitored, so people do believe that QCT densitometry will pick that up more, greater effect of trabecular bone. And the reason is that QCT densitometry can distinguish trabecular versus cortical bone. And if we're looking at trabecular loss, then certainly this is even better than aerial bone density or DEXA in looking selectively at the trabecular compartment. So this is absolutely true. When we do aerial bone density at the spine, for example, which has the most trabecular compartment, you still have the posterior elements, the cortical elements of that vertebra in the aerial bone density itself. And as we know with age, significant amounts of degenerative change occur, osteoarthritis, end plate spurring, this and that, aortic calcification, whatever it is, this influences our DEXA, our aerial DEXA bone density. So the most precise way of knowing what's happening in the trabecular compartment would be exclusion of all those potential artifacts, the posterior elements, everything else. And so QCT is actually the best technique to look at purely trabecular bone. Most of us don't have that ability. There is significant exposure to radiation compared to just aerial DEXA bone density testing. So most of us do aerial DEXA bone density testing. It's not bad. It just means that one is actually more precise than the other. In patients on glucocorticoids, increased fracture risk is independent of decrease in BMD. The FRAX score underestimates the risk of fractures. The FRAX score overestimates the risk of fractures. So you can't have it both ways. You gotta tell us what you think here, because you're going to see these patients in practice. And remember, this patient had a low FRAX risk. All right, so everybody believes that A and B are appropriate. So increased fracture risk is independent of BMD. That means that when you look at fractures with glucocorticoid therapy, frequently it is in osteopenic patients and also in patients that have normal BMD. So there are qualitative changes in bone that we don't see or are undetectable with glucocorticoids. So this is one of the key issues in regard to just doing bone density testing alone. FRAX score. Now, when you click prednisone or glucocorticoid therapy in FRAX, that is not inclusive of high-dose glucocorticoids. We're talking about 5 to 7.5 milligrams in the general practice UK assessment of patients on glucocorticoids and the risk associated with those doses. So anybody that has more than 7.5 milligrams of prednisone, they're not included in the yes or no glucocorticoid in the past button that you're pressing. So those individuals with higher than 7.5 milligrams, FRAX is underestimating that patient's risk of fracture. Okay? Yes?
Wouldn't the FRAX from this gentleman be premature because it's being done before he started?
Well, that's what we're saying. So we're saying that this is underestimating this patient's future fracture risk. If you did it just before, if you did it within 1 week of institution of prednisone therapy, his BMD won't change 1 week later, but he's on therapy. Okay? What we're saying is either way, whether it's before treatment or just after institution of treatment, it'll be underestimated. FRAX will be underestimated. His risk or her risk of fracture based on high-dose glucocorticoids for GCA in this patient is high. Bless you. So this patient's risk of fracture is underestimated by FRAX. Okay? Any question about that? And you have to use other criteria for prevention, potentially, of fractures in this 72-year-old individual. The following are true. Inhaled glucocorticosteroids do not induce bone demineralization. Doses of 2.5 or less do not induce bone demineralization. Patients on glucocorticoid therapy for adrenal insufficiency are at very high risk of osteoporosis. A and B, or none of the above. All right. I think we've all elected what to do here. So let's discuss inhaled glucocorticoids. Firstly, in low dose, they may not have an adverse effect, but there's some data to suggest that very high doses of inhaled glucocorticoids have a detrimental effect, and that's seen in the biochemical markers of bone remodeling in these individuals. And this is also in the FRAX Physician Development Conference in 2010, we looked at this as well. So the usual doses of inhaled steroids, the expert panel could not come to a decision that regular dosing of inhaled steroids made a big difference, but they thought that very high doses could be associated with increased risk of bone loss. So there's this debate that's going on in the community of bone at this time. Okay. Doses of 2.5 or less do not induce bone demineralization. Well, we know it's a dose effect, and Cyrus Cooper actually published this data years, I think it was Cyrus Cooper, wasn't it? He published this data years ago showing that 2.5 milligrams induced loss of bone mass as well. Less than that, nobody has really looked at that. But we know as part of the FRAX algorithm, and the studies that John Canis actually published, who was involved with FRAX development at the WHO, with Cyrus Cooper, I believe, published data showing that if a patient was on less than 2.5 or less than that, that FRAX is overestimating fracture risk in patients on very low dose steroids. Patients on glucocorticoid therapy for adrenal insufficiency are at very high risk of osteoporosis, and that is incorrect. So there's no data that very low dose hydrocortisone or the equivalent therapy in patients with adrenal insufficiency result in steroid-induced osteoporosis. There's no data to that effect. Ron, any comments? Okay. Let's continue on. Glucocorticoid therapy induces bone demineralization by inhibiting osteoblasts, stimulating osteoclasts, increased expression of rank ligand, which we talked about, increasing osteoblast-generated rank ligand to stimulate osteoclasts, decreased osteoprotegerin expression. We talked a little bit about the osteoblast having the schizophrenia, in which that also produces osteoprotegerin, but also rank ligand. One inhibits the same other product by the osteoblast, and then all of the above. What do you think? So those that are voting who have a feel for this basically have suggested all of the above, and steroids, glucocorticoids, do inhibit osteoblasts directly. It causes osteoblast apoptosis. It stimulates osteoclastic activity, including by the rank ligand system, and it depresses osteoprotegerin because it's also decreasing osteoblast formation of this product. Glucocorticoid therapy induces demineralization also, maybe, by reducing GI calcium absorption, increasing renal calcium excretion, reduce gonadal hormone levels, all of the above, none of the above. So we're looking at the pathogenesis of glucocorticoid-induced osteoporosis. Anyone else wish to take a shot at this? Okay, so let's proceed. So it does reduce GI calcium absorption. It increases renal calcium excretion with sodium and calcium excretion. It reduces gonadal hormone levels, so we have a suppression of normal hormonal production. And so it would be definitely all of the above. So glucocorticoid therapy increases the risk of fracture by impaired bone strength, muscle atrophy, impaired neuromuscular function, all of the above, none of the above. And everyone that's voting here believe all of the above, and that is true. So we have steroid myopathy. We certainly have impaired bone strength due to these factors, and aerial DEXA bone density doesn't pick up all these qualitative issues because we know patients fracture with osteopenia and even normal bone mass. And certainly there's impaired neuromuscular functions. Management of glucocorticoid-induced osteoporosis includes anti-resorptive medications, osteoanabolic medical therapy, raloxifene, hydrochlorothiazide, all of the above. What do you think? All right, so most individuals have picked all of the above. So the anti-resorptives we talked about, most of them are available for use. We know that alendronate for treatment, risedronate for prevention and treatment have been released. Certainly zoledronic acid, also called Reclass, is proven to be effective. Denosumab we talked about as an anti-resorptive has not been shown because they did not do the research with in an FDA-approved registration trial with glucocorticoid-induced osteoporosis. Doesn't mean it doesn't work, but it hasn't been shown. Osteoanabolic agents, so actually there's a 36-month trial with teriparatide. 36 months, not mean 18 months. 36 months. And this is the only trial of long-term glucocorticoid therapy with teriparatide. I mean, this is the only registration trial of 36 months. And they found that there was significant increased bone density in these patients, and even between the second and third year, they still had bone accrual. Raloxifene, is that released for glucocorticoid-induced osteoporosis? I don't think so. So could you use it if that was the only agent available? I guess you could, but it's not FDA approved for it. Okay. Hydrochlorothiazide, decreasing the hypercalcemia of glucocorticoid-induced osteoporosis. Yes, you could use that if you proved the patient had hypercalcemia associated with it. So that those would be the answers that I would think. Any other comments regarding that, Ron? No? Okay. Now, monitoring. How would you monitor this patient? Annual DEXA scans, annual or semi-annual QCT of the lumbar spine, annual x-rays of the lumbar vertebra, A or B, or A, B, or C. A, B, or C. What do you think? This patient has come to you. This is not an unusual patient. It may not be for GCA. It may be some other disease process. But how would you monitor this patient's skeleton to be sure that whatever you do is making a difference? And you certainly would want to intervene early on in the course of the patient before they lost 30% of their bone mass and had a fracture. So most of the individuals believe A or B. So annual DEXA scans, certainly you can do this. And Medicare CMS actually approves every 6-month DEXAs in glucocorticoid-treated patients. And so if you have your precision ear, you know your least significant change, as we talked about, then you could do a DEXA scan every 6 months. Precisely the same regarding QCT. You're selecting out trabecular bone, determining if your treatment is effective. Can you imagine following your patient every 6 months with QCT and finding that despite being on oral alendronate or risedronate or ibandronate or whatever, the patient's still losing bone mass? You're going to switch, right? You're going to absolutely switch to a more effective or more significant drug therapy to prevent bone loss. X-rays of the lumbar vertebra. Now, would you use that? You could, but you'd actually want to do a vertebral fracture assessment or imaging, plain films of the entire spine on a regular basis, because vertebral fractures can be asymptomatic. They don't have to be symptomatic, and that changes your whole approach. Okay, you're on an oral bisphosphonate. You know, the patient has had a fracture. You know, are you really comfortable with that? You certainly would also consider, when you did the DEXA bone density initially as a baseline, you'd also want to consider a VFA as a baseline, because then you know whether the patient had a prevalent vertebral fracture that was asymptomatic prior to institution of therapy, meaning any of your therapies. Okay, monitoring bone status. Would you do an annual serum 25-hydroxy-D level? Would you get annual body heights? So heights of the patient. incidence of vertebral fractures, would you want to look at that? In other words, whether the patient had an incident vertebral fracture. How would you like to monitor this patient? All right. I think we have most of the folks that are going to vote today. So, yes, you would do a 25D on a regular basis because we know it affects vitamin D metabolism. And also as individuals gain weight, potentially on steroids, increased adiposity also has an influence on vitamin D, 25D levels. We know that annual body height, so you would then at the base, you would do a height as a baseline, compare the patient to their historical height at 18, and then prospectively measure their height on a regular basis to make absolutely certain they haven't sustained prospective height loss, which would be considered a potential reason on their next clinic visit to repeat spine x-rays to be sure the patient did not sustain an incident vertebral fracture. And of course, you'd question the patient about non-vertebral fractures that occurred between their visits. Any other suggestions, Ron?
That's about it.
Okay. All right, and these are the take-home messages. And just to summarize, inhaled glucocorticoids in high dosage we are concerned about. And certainly intranasal, inhaled, oral, are all of concern, and many of our patients are on combined intranasal, inhaled for pulmonary as well. You have to think about this as part of the overall process of glucocorticoid excess. Glucocorticoid-induced bone demineralization, most pronounced during the early treatment phase, but it continues a long-term unless treated. You'd certainly want to, the most desirable aspect of prevention here is to assess the patient early on, prevent bone loss. Systemic mechanisms we've talked about, and bone-specific cellular actions we've also discussed in regard to osteoblast inhibition, stimulation of osteoclasts, and also the adverse effect of steroids directly on the osteocyte and leading to osteocyte apoptosis. So the osteocytes are the regulators of the skeleton as well, and this is inhibitory to the cell line as well. Okay? Any questions?
There's one more.
Oh, there's one more. So glucocorticoid-induced increased fracture risk is independent of decreases in BMD. We talked about that. So patients may have osteopenia, they may have normal bone mass, but still qualitative changes are occurring in these individuals that are not necessarily apparent on aerial DEXA. It's associated with increased fragility of bone, muscle atrophy, including steroid-induced myopathy, neuromuscular dysfunction. FRAX underestimates fracture risk in patients on significant doses of glucocorticoids, over 7.5 milligrams a day. Normograms are available to estimate fracture risk in patients on glucocorticoids, and certainly one by the American College of Rheumatology has normograms that relate to the patient's FRAX risk and which medical therapies to utilize and how to monitor these individuals. You would certainly want to modify all other risk factors as well in these patients. You want to continue muscle weight-bearing activities, decrease alcohol, smoking, everything else that could adversely influence the skeleton. And with that, I'll take any questions, and then we have a break now, don't we?
Right.
So if you want to take a break now. Come on up. and we'll be happy to attempt to answer any questions you may have.